Welcome to myheart.net, and today we're going to talk about cardiac CT from diagnosis to prognosis and talk about what cardiac CT shows. With me today, I have Dr. Satinder Singh, who's professor of radiology and medicine in the Division of Cardiovascular Disease at UAB. He is the chief of Cardiopulmonary Radiology, as well as director of the Cardiac CT and director of the Combined Cardiopulmonary and Abdominal Imaging Fellowship Program at the University of Alabama Birmingham. So, Dr. Singh, welcome to our presentation this afternoon.
Well, thank you very much, Alan, for the invitation. And it's pretty nice weather outside, and we are inside doing this podcast.
Anything for our patients, right, Dr. Singh?
Right, that's true.
Well, we did a podcast on cardiac CT, and we thought it would be important that beyond the discussion, that we would share some images because it's about cardiac imaging, really. First, Dr. Singh is going to talk about the calcium score. We talked about the importance of the calcium score and how it helps us decide whether the patient should be treated with certain medication or not, and it gives us an idea about prognosis. For example, calcium score of 0 has a very low cardiac morbidity and mortality over the following 10 years. It's usually in the order of 0.3%. However, when we have very high cardiac calcium score, if it's greater than 1,000, for example, the cardiovascular morbidity and mortality is as high as 8%, which is pretty much similar to what was found in the Fourier study, which studied a patient with, which was a second prevention trial of evolocumab or Repatha in patients that have coronary artery disease. The cardiovascular mortality and morbidity was as high as 7% in the Fourier trial. So some calcium score gives us an idea about preclinical disease, particularly when it's very high. In addition, we'll discuss about coronary CTA or coronary tomography angiography, which is more and more incorporated in clinical practice. And I just want to remind you of the Scott Heart study, which studied over 4,000 patients that presented in the emergency room with chest pain and atypical chest pain. Compared to standard clinical practice or standard treatment, and evaluated these patients for 5 years. And they found that a patient that underwent cardiac CT had improved and lower cardiac mortality and myocardial infarction compared to standard of care. And over a period of 5 years, it was a patient that underwent cardiac CT was 2% mortality and myocardial infarction versus 4% standard of care. And all of this because patients were allowed to find out whether they have coronary artery disease and were treated more appropriately, maybe with aspirin, a statin, as well as Plavix, as well as patients were not given unnecessary treatment if they didn't have any coronary abnormality. So the cardiac CT, the score, as well as cardiac CT angiography allows us for better care in these patients. And with this in mind, I will let Dr. Singh present some cases of cardiac score, calcium score, as well as CTA. So Dr. Singh.
Thank you.
The podium is yours.
All right. So as Dr. Bouchard mentioned, coronary artery calcification has a significant role in the risk assessment. It has added value to the conventional clinical risk assessment. And the calcium score is done by a non-contrast CT, and there is no special preparation is required. Scan is done within few minutes, or actually within few seconds, and then the machine software analyzes for any calcification in the coronary arteries with a threshold more than 130 Hornfeld unit. For example, this is a 66-year-old male with hypertension, hyperlipidemia, and his calcium score was 6, and you can see a tiny speck of calcification in the left main. And the machine also generates this distribution of the calcification, and it shows the calcification is mostly in the left main. So according to the criteria, the coronary artery calcification of 6 fall into 1 to 10 category, which means there's a minimal plaque and a very low cardiovascular disease risk in the future. On the other hand, this is another patient with the hypertension, hyperlipidemia, but he's asymptomatic, and his calcium score came out to be 104, and it is shown here as red specks in the LAD, mostly LAD category. So this score of 104 is between 101 and 400, which means it is a moderate plaque burden and has a very high cardiovascular disease risk in future. If you look at this numbers here, this is the total radiation dose on these cardiac scans. In this patient, it is dose length product, DLP is 28 milligray per centimeter, and turn out to be effective dose is 0.39 millisieverts. So it is very, very low dose scan, which has a very useful information. This is another patient who came here for coronary artery calcification. He has multiple risk factors, and his coronary calcium score was very high. It was 684. And based on our classification, this is extensive plaque with very high cardiovascular disease risk in the future. As you can see, the red is in the LAD and the blue is in the RCA. So both in the proximal RCA and the LAD, and the distribution is listed here. Now, there are several people debate about, doing coronary CTA in patients who have a very high coronary artery calcification. I will give you one example in favor of doing CTA, despite having very high coronary calcification, because there are some added advantages. So this patient's score was more than 2,000. You can see very, very extensive calcification in the LAD, and he was symptomatic, and we were able to control his heart rate quite low. It was around 58 beats per minute, very regular, and we end up doing a coronary CTA, and the quality of study was excellent. So here is the example of the LAD, the same vessel here. It is stretched out in a straight view, and these are the cross-sectional images at different level. As you can see, this red area here correspond to the most heavily calcified area, and on the cross-section you can see circumferential calcification with the lumen, which is kind of narrowed. But we know when you have a dense calcification, there is a blooming artifact. That means lumen is actually bigger than what it appears. So this patient actually did not have significant, if you consider everything, we characterize it as around 40% narrowing, taking care of the blooming artifact. But what was interesting is this is his RCA, distal RCA, before the bifurcation into PDA and posterior lateral branch. And you can see this patient has a critical stenosis in the distal RCA with mostly non-calcified plaque with some calcifications in it. So this was an incidental finding which was detected in this patient with very high calcification score. So this is the reason why coronary CTA can still evaluate those coronary segments which are not heavily calcified. Of course, calcium still remains biggest threat for coronary CTA, despite advances in the technology of cardiac CT. If the quality of the study is not good, and there are other factors such as motion artifact or breathing artifact, or contrast is not very good, and you don't have a good view of the coronary artery, there is tendency to overcall the stenosis. So this was a patient, a 56-year-old with atypical chest pain, hypertension, diabetes, and hyperlipidemia. And we did a coronary CTA. He was kind of bigger guy, and his IV access was only 20 gauge. So we could not give more than 4 cc per second rate of injection. Ideally, it should happen at least 5 cc. And what we saw was in the LAD, there was this plaque which was calcified, and the lumen looks quite narrowed. So we raised suspicion that this probably is significant calcification, significant narrowing, more than 50%. but patient was taken to cath, and you can see there is not much stenosis here. His stenosis was around 20 to 30%. So calcified plaques still give rise to false positive findings and due to overestimation of stenosis. So we have to be very, very careful about this finding. Now, moving on to coronary CTA, we don't usually do coronary CTA in patients who are asymptomatic. It is not a appropriate criteria. However, if patient is willing to pay and they can get it done, studies can be done. So this is one of the examples which was given to me by Dr. Jim Taylor. This is a 44-year-old male who has a very strong family history of coronary artery disease. He was asymptomatic, but his brother died actually around this age. So he was very, very scared. And his group had bought a cardiac CT at that time. So he was able to get a cardiac CT very easily. So what we see here is, this is the left main coronary artery and it's going into the proximal coronary artery. There is a long plaque, which is mostly non-calcified. Okay, and here is a zoom view. This plaque is extending from left main into the proximal LAD. And in fact, if you look at the lumen, this is approximately 50% or maybe slightly more narrowed, but he is asymptomatic. In addition, he did have other disease elsewhere in the distal LAD as well as RCA. So based on all these findings and his family history, he was put on statin, and we got another follow-up CT. And this is a really good teaching point, because at that time, we were not expecting to see these kind of effect on these patients. So this is his baseline CT, and this is a follow-up scan, and you can see the plaque, which was quite significant here, has decreased in volume. And also you see this calcification, which was not there or very faintly there, it's obvious. So what we determine based on these two scans in one patient, that the plaque volume is decreased and it is more calcified, suggesting stability, suggesting that this is one way of objectively looking at effect of statins in these patients. And I think subsequently there are many other research papers which have came out and showed the same finding. This is another 57-year-old male with hyperlipidemia, and this was his baseline CT. Why he got CT? He's asymptomatic, self-pay. Why he got CT? Because he goes to scuba diving every year, and he just wanted to make sure everything is fine. And this is the best way to do non-invasive. So you can see a very fine speck of calcification, non-obstructive, and he was fine. But then he, after 2 years, he got another scan. At that time, his calcification became more denser. Lumen may be slightly narrowed, but nothing significant. Now he was put on statin. And after that, he started getting, scan 1 or 2 year after. And you can see the calcification density as well as the volume has not significantly changed over 3 years. So I think down the road, this may be an important modality to objectively evaluate effect of the therapy on the coronary atherosclerotic plaque, especially if the scan is easily done, it is shorter duration, and the radiation dose, which is the biggest factor, is much lower. If we can do a prospective scan with 1 millisievert or 2 millisievert, I think this will be the fabulous way of a screening coronary CTA for atherosclerotic disease and looking at the effect of therapy. Now, when you look at the coronary CTA, there are different ways to look at, but mostly start with an axial view. And you can see this is a prospective gating and only one phase. And as we go down, this is the ascending thoracic aorta. This is the pulmonary artery. Behind is the branch of the pulmonary artery here, and this is the left atrial appendage. And as we go down, here is the left main coronary artery. And you can already see that in the proximal LAD, there is a long plaque, which is heavily calcified in mid portion, but then it's a more mixed variety, more distally. And as we go distal to that, you can even see the one diagonal branch also show this kind of mixed plaque, and LAD gradually tapers toward the apex. There is a small superficial myocardial bridge here, and then it goes to the apex and wraps at the apex. And similarly, you can look at the other coronary artery branches. Here is the circumflex branch. As it go into the left AV groove, it gives rise to several smaller OM branches, and then it continues as a large OM branch in the left AV groove. The RCA similarly is a dominant vessel. It gives rise to several acute marginal branches, and it is in the right AV groove, and near the crux it gives rise to the biggest marginal, and then posteriorly it divides into the PDA and the posterior lateral LV branches, all good. So axial scan actually give you a lot of information. But since we know the coronary arteries are tortuous, so you may not see the entire vessel in one plane. So you have to kind of imagine in your brain, if you have continuity of the vessel. On the other hand, you can also do multiplanar reformats. So that can be done with the machine. If you pick certain points, it will draw a line and show you the vessel, or you can do it manually like I'm doing here. This is just a zoom form. It can show you this. The multiplanar reformation is possible with coronary CTA because of the isometric imaging, which means the X, Y, and Z axes are the similar resolution. So when you rotate these images, there is not much degradation of the image quality. So when you have a diseased vessel, what you want to do always is to look at the cross-sectional view. Here is the non-calcified plaque, and here's the lumen. As you follow this more distally, you will see the lumen get narrowed quite a bit. Then there is a mixed plaque here, and the lumen is almost 50% or more narrowed, and then distally it is all okay. Now on the right side, you can see a volume rendered image. What it means is you are seeing the structures of the heart more superficially. This is the left ventricle, this is the right ventricle, RVOT, and the pulmonary artery. Here are the pulmonary valves. This is the right atrium and the big pyramid-shaped appendage. And this is the right coronary artery, seeing very clearly. Then you can rotate these images and look at the rest of the coronary artery. Here is the LAD, and here is the circumflex, and that's the left main branch. These are not same patient, these are two different patients. This scan on the right is totally normal. This does not provide much useful information regarding the coronary artery lumen, but it gives you a lot of spatial correlation with the surrounding structures. So very, very useful for congenital heart disease, or if you're looking at the anomalous coronary arteries. Now we know the coronary arteries move a lot. This is a patient where we did a retrospective gated study, and you can see the right coronary artery moves a lot. So that is the biggest challenge in evaluating coronary artery. It's like a moving target, how you do that. And that's the one reason why newer scanners, which have a better temporal resolution, are able to freeze this motion in a space in a particular phase of the cardiac cycle. And so you can have the entire information. This blue lines are the R to R interval, and you can see this red dot is moving all the way through R and R. So you have the entire cardiac cycle information in the scan. Of course, the penalty for this kind of scan is the radiation is slightly higher, but again, with the newer scanner, radiation can be much lower, around in the range of 3 to 5 or 6 millisieverts, as compared to 20 or 15 millisieverts, which have been reported earlier in the literature. Now, when you evaluated these kind of studies, it's very important to look at different phases, what phase you are looking at. For example, if you look at this phase, it is very blurry. The noise level is very high. And this is the left main coronary artery. It looks like almost there is almost occlusion of the mid portion of the left main, and even the LAD and the diagonal branches are not well seen. But if you look carefully, we are at the 0% phase. This is not the end diastole phase, late diastole phase, where the coronary artery motion is least. So if you go to that phase, which is here, Now you can see all the vessels much nicer. So very important to pay attention to these phases when you have a multi-phase exam. Also, if you notice, the scan on the left side is much more noisier because we use dose modulation technique, which means the radiation dose is maximum during the late diastole and it is least in the systolic phase, because what information we need is mostly in the late diastole. But since we have entire cardiac cycle, despite low dose, we can still evaluate cardiac function. We can derive all kind of volumes and ejection fraction, etc., from this study. So this is a 44-year-old physician who has history of tachycardia, exertional chest pain, and sweating. Very typical angina kind of picture. So he got a stress test, which is normally a first modality to look at, and he had a normal stress test a month ago. He had a very strong family history of coronary artery disease. He has asthma as well as diabetes, so very, very strong risk factors. So this was in around 2006 or 7 when we bought our cardiac CT, and he was willing to undergo a cardiac CT non-invasive evaluation of coronary artery. So you can see this, it was a good scan, and we did control his heart rate. You can see the LAD, this is the first diagonal branch, and there is a tight stenosis here. This part, there are 2 calcific specks here, and this part of the coronary artery segment near the septal branch is not opacified, but distally there is a good flow. And also, if you note, the diameter of this vessel as compared to the proximal and more distal vessel is actually smaller. This is called negative remodeling, which usually indicate it is the later stage of the plaque remodeling, which is more fibrotic. So based on these findings, he was able to undergo catheterization and ultimately was stented. And this is again volume rendered image, which can show the topographic evaluation of the coronary arteries. And you can see even in this case, a tight stenosis of the LAD. So very useful information. And last thing on this side is what we call CT ventriculogram. You can actually, you can actually look at the global function of any regional wall motion abnormality of the left ventricle. So what you're seeing is all the vessels, all the walls of the left ventricle are moving very well. And this is a very useful information in patients with dilated cardiomyopathy or patients who have Takotsubo disease or hypertrophic cardiomyopathy. Here is a good example. This is actually a study case. It was enrolled in a study where you do a CT and then MPI, and they get either undergo intervention or medical therapy. So this patient underwent a CT arm, and you can see a very significant non-calcified plaque. So this patient, if you do a coronary calcium score, it will be 0, but he has a very significant disease. It was more than 70% narrowing of the LAD. And you can see in the color format, same vessel here, and almost you cannot see this branch. Proximal LAD is totally occluded, almost totally occluded. And you can derive, various reformats, nice looking images, but it does not give you much information, just pleasing to eye. And he underwent MIBI scan. So what we have is at the baseline scan, stress scan at the top, and this is the stress scan after his medical therapy, intensive medical therapy, after almost a year later or 8 months later. So you can see there was a big defect in the LAD territory of the myocardium, and which after medical treatment significantly improved, almost nearly gone. And here is the bullseye measurements of the defect of the myocardium. Initially in the baseline, it was approximately 40% ventricle which was involved, and then on treatment it was brought down to 9%. So this is another example that not every patients with coronary artery disease due to plaque need intervention. They can be treated with intensive medical therapy, and this is a good example of that. Now, this is another interesting case. This patient had intramural hematoma present to ED with acute chest pain. And we do all scans when you suspect aortic dissection as a retrospective gated study, because the aortic root shows a lot of motion artifact. So this was done as retrospective gated, and you can see there is an left main ostial stenosis, and there is a mild post-stenotic dilatation. And this is all due to intramural hematoma. This soft tissue thickening is the wall hematoma in the wall of the ascending aorta. And you can see also here, this is all hematoma leading to narrowing of the left main ostia. So this patient underwent stenting and he did well. The intramural hematoma gradually resolved. He did not undergo any surgery. It was only stented. So other non-atherosclerotic disease can also involve coronary artery, such as this, and can lead to significant narrowing and symptoms. This is another patient, 39-year-old, who had a replacement of the ascending aorta with the pseudoaneurysm formation after the surgery, and then now he's presenting with severe chest pain. And this was just a regular CTA done without gating. We call it high-pitch non-gated scan. This was done at the outpatient service. And you can see this patient had underwent a Cabrol procedure with a large graft which is surround the ascending aorta, and then the left main is connected to that. And the patient had an aortic valve replaced. All the other vessels were normal, but if you had looked at carefully, the Cabrol graft to left main or LAD junction was tightly narrowed right here. And here are the static images. You can see very tight narrowing. There is a good distal flow, but this is very, very tight narrowing. And that's probably the reason he was having severe chest pain. And patient underwent cath, and it corresponded exactly what we saw. And he underwent stenting, and he was doing well after this. So unusual appearances, unusual cases, but CT can help detect all these subtle abnormality in complex patients. Now, moving on to plaque characterization, there are several features, CT features of high-risk plaque, which are shown here. Number one is if the plaque volume is larger, if it involves more proximal vessel, if it involves the left main, it is considered more high risk. So large plaque volume and a positive remodeling, that means the distance from outer wall to outer wall is larger as compared to the normal vessel. This is positive remodeling. We saw a case of negative remodeling where the outer to outer wall is narrowed because that's a later stage of plaque remodeling. And third is when the plaque density is very low. In this case, it is less than 30. So that indicates usually this is a lipid-rich plaque, which is often considered a very vulnerable plaque, which can rupture. Presence of spotty calcification. Here, the dense calcifications in a mixed plaque. And then is a napkin ring sign, which is shown here. And you can see the fine line here, high density surrounding the low density. That is the napkin ring sign. This is a more recent case where we did an ED scan, no heart rate control. It was just a chest pain. And we could see some of the coronary arteries. And this is the LAD. And you can see in the mid LAD, there is a non-calcified plaque here. And there is a high density around. This is a lipid-rich, plaque, which has a napkin ring sign, one of the most recently described feature of a one-level plaque. So these are the plaque features, which are, if you have it, they suggest that there is a good risk of further rupture and leading to a significant event. Now, sometimes we see the effect of coronary artery disease on the myocardium incidentally, not looking at the coronary artery per se, but the effect on the myocardium from the disease. Here are a couple of examples. This is a 47-year-old female who has SLE, hyperlipidemia, and renal disease, presented with atypical chest pain, and CT, most common indication in the ED is for PTE. So we did a PE study here, and if you look, I mean, not a great study, but still it is good enough diagnostic. We did not see any PE, but keep looking at the myocardium. This is a normal appearing myocardium, but as we go down, this myocardium is hypodense as compared to the rest of the myocardium. And the density of that myocardium is low and the thickness is maintained. That means this is an acute event. If it is a chronic myocardial ischemia or scarring, the thickness of the myocardium will be decreased. In this case, it is not. So based on these findings, this is a classical RCA territory myocardial infarction or ischemia. He underwent CTA, and of course, there was a very tight stenosis in the distal LAD before the bifurcation, and he was stented, or she was stented, and she did well. So incidentally, always look at the myocardial perfusion defect. This is almost like a resting perfusion of the myocardium. If there's a defect and the wall is not thinned out, which can happen with chronic MI, always suspect that this patient may have coronary artery disease causing myocardial ischemia. We have seen similar kind of picture in patients who come for trauma. This is a 53-year-old who had fall from 20 feet height. He had multiple fractures, so we always do trauma, chest, abdomen, pelvis. And this study was done, and you can see, not a good quality study, but you can clearly see the hypodensity of the myocardium, classical LAD territory. Rest of the myocardium normal. And we alerted, that this patient probably has myocardial infarction. We do not know whether because of infarction he fell down or infarction happened later. But nonetheless, we said, do some further testing at least. And we found out that his creatinine troponin level was much higher. I mean, this was baseline. And as you look at a serial troponin level, it went high on the roof. This patient actually could not undergo any therapy because of his fracture. They cannot heparinize him. And he was discharged after 2 weeks, but unfortunately he expired at home, and he had an autopsy actually. And at autopsy, we could see the subacute myocardial infarction, but his cause of death actually was PTE. So nonetheless, we are seeing the effect of coronary artery disease on the myocardium, which can be incidentally picked up on a routine chest CT done for some other reason. So coronary stent evaluation is still a problem, especially for distal small stents, but they can be evaluated with nicely if the stent is larger and is more proximal. Various stent factors which affect coronary artery stent evaluation is the size of the stent, what design it is, what material it is, and of course, if it is adequately dilated at the time of placement or not. So this patient has this multiple overlapping stent in the LAD. You can see, you cannot see within the stent itself, but if you look at the densities, I mean, it is all high. This is a blooming artifact, that's why the numbers are high, but this stent is patent and there is a good distal flow. On the other hand, this patient has a stent in stenosis. You can see this hypotenuating black line. It is not occluding it, but this is the early stages of stent in stenosis, not significant. And this is the case of total stent occlusion. Again, you can see you cannot really see within the stent very clearly, but if you don't see the distal flow and there is a proximal hypoattenuation, that indirectly suggests that there is a stent occlusion. Here is another example of a 280-pound patient, 39-year-old, who has coronary artery disease, who had a prior RCA stenting and had an inconclusive stress test with persistent atypical chest pain, and we did a coronary CTA. And we see a stent, a large stent in the distal RCA. You cannot really tell, and you do see some contrast distally. We could not give well, actually, we did give 5 cc per second rate, 80 cc of contrast, and his effective dose in this retrospective Gary was 9 millisievert, considering he's 280 pounds. And when you reconstruct these local RCA stent, doing a thinner images, this is a 0.5 millimeter stent, and you can see stent slightly better. But if you reconstruct with a sharper filter, you can start seeing more inside. Of course, there is much more noise. This is not the best quality because of the patient's age. So based on this, we said we do see distal flow, but it is not good. It may be just the patient's body habitus, but since patient was symptomatic, he was taken to cath lab, and it showed that the area which we thought may have distal less flow, it was totally normal. It's only just 20% distal stent stenosis. But this is like follow-up examination of this patient after several months. He get another exercise SPECT, and that clearly shows that there is an RCA defect here, approximately 13% of the LB. I do not have any follow-up. So when you're looking at stents, there are various ways to improve the stent visualization. Before doing the scan, you might want to use a higher MA. Of course, it will increase the radiation dose, but it will improve the contrast resolution so you can see stent better. You may want to increase the contrast density, but which is not usually applicable. Many of the places only have one type of contrast, like we usually use 350 milligram of iodine, but there are higher density contrasts available. And also you want to use the higher flow rate. And of course, you want to decrease the heart rate as low as possible, close to 60. And then after the scan is done, you can use this sharper kernel reconstruction and thinner images, which can improve the stent visualization. This is the patient, a 46-year-old who had an anomalous right coronary artery arising from the left coronary cusp. So this is the left main, this is the left cusp, and the RCA was arising from this. This is right cusp and non-coronary cusp. And this patient was treated with a stenting, which is very rare. Most of the patients who are symptomatic, they undergo unroofing or sometimes CABG. In this patient, he had a stenting done. And since he was having some symptoms, we looked at his coronary arteries. This stent is clearly patent. You can see nicely the contrast, no in-stent stenosis within it. So here is the two different kernel, which I showed you, smooth kernel and a sharper kernel. You can see the sharper kernel is helpful. This is a 58-year-old male who had CAD and multiple CABG, presented with chest pain. We often do CTA because CTA is very good at looking at coronary artery bypass grafts, because these grafts are away from heart, so motion, cardiac motion does not affect many of these grafts, and you don't have to really control heart rate. So CTA was done in this patient. This is a prospective CTA. We usually start above the clavicle, so you can look at the origin of the graft, which is often the site of stenosis. Here is the left internal memory graft arising from the left subclavian artery. And as we go down, it is tortuous, it is well opacified, it goes more laterally along the chest wall, and you can see it is anastomosing with the LAD and has a good distal flow. However, there is a larger saphenous venous graft here, which is totally occluded. And this graft is connected to the obtuse marginal branch distally. There is another right saphenous graft, which you can see here. Right there. So if you look at this graft actually is not a saphenous graft because it is much smaller in caliber. It is actually was a radial graft. But there is a disease, if you look carefully right there, there is a significant disease which is causing narrowing of this graft. So this patient underwent catheterization and underwent stenting at this area. The saphenous, left saphenous venous graft, they cannot do anything, but they did stent at this. So CT is a good modality to look at various types of grafts, patency, as well as complications. We have seen coronary artery bypass graft aneurysm formation with thrombosis, with fistulous communications. Here is a patient who had a long saphenous venous graft. You can see the stent, large stent, patent, but there is the early atherosclerotic disease changes in the stent itself. you can form this reformatted 3D reconstruction. Very nice to look at the course of these vessels. This is a 293-pound patient who have multiple saphenous venous grafts. The baseline CT in this patient show very minimal disease here, but 3 years later, this disease has progressed, and he was still not very symptomatic, but after few months, he became symptomatic, at which time the cath was done. There was a stenosis and he was stented. So despite this noisy images in a bigger patient, I think we can still evaluate the graft as well as stents in these patients. And this is just a reformat. You can see this tortuous vessel, Lima graft, which is behind the sternum. And this is an important information if the patient is undergoing a repeat coronary artery bypass surgery for reduced sternotomy. You're looking at where exactly is the graft, and here this graft is very, very close to the sternum. So you have to be very, very careful not to cut this branch when you reopen the chest. Now, sometimes there can be other causes of chest pain. 67-year-old female who came to ED with chest pain, of course, clinically suspected aortic dissection. We do a retrospective gated study, and heart rate is not controlled. You can see this band artifact. This is a motion cardiac related artifact, but this doesn't matter for the aorta. But we found, incidentally, an anomalous right coronary artery, which is arising from the left cusp. So this is the left cup, this is left main coronary artery. Here is the anomalous right coronary artery arising from the left cusp. Pulmonary artery, here is the pulmonary valve. So this is coursing in between the pulmonary artery and the aorta, and its course is oblique and narrowed. So we call that this is probably the cause of this patient's symptoms. Since she's 67-year-old, we were not sure what exactly needs to be done. So the next step was they said, okay, let's look at the effect of this, if there's any effect of this abnormality on this perfusion scan. And this patient did had a perfusion defect in the RCA territory. So then they did a limited injection. When you inject the left main coronary artery, you can see faintly opacification of the RCA, which has an anomalous course. So this patient underwent surgery, and she was asymptomatic after surgery. So rarely anomalous coronary artery can present in this age group with chest pain. For whatever reason, if there is atherosclerotic disease now, which is causing stenosis, or this is causing stenosis because of the origin or dilatation of the pulmonary artery with age, causing more compression, we do not know. But you can see these kind of pictures. Here is another example. He's a lawyer. He was a lawyer, actually, came with chest pain, went to his cardiologist. So first thing they did was, let's do a cath. At that time, that's probably the best way to look at it. And they injected the left coronary artery, which was normal. They cannot evaluate the right. They could not hook up right coronary artery. So he's young, so they said, rather than doing CT for radiation, let's do MR. So this is a corresponding one image where you can see the left coronary artery nicely and part of the right coronary artery, but we do not see the origin of the right coronary artery. Now, MR images are very thick images, often 6 to 8 millimeter, or sometimes maybe 4 millimeters. So that leads to poor resolution, spatial resolution as compared to CT, where you can go as thin as 0.5 millimeter. So then he underwent CTA, which clearly showed that there is an anomalous right coronary artery arising from the left cusp, going in between pulmonary artery and aorta. This is a different way of looking at it. This is called spider view. This is a normal in the bottom. This is the right cusp, left cusp. Here's the right coronary and left coronary artery. But in this patient, the right cusp was empty and left coronary artery was arising from the left cusp in between the two vessels. A nice 3D reconstruction, volume rendered image. So this patient underwent surgery afterwards. Another patient, we can see clearly the origin of the right coronary from the left cup. It is very near the commissure. So these kind of patients, especially if they have an intramural component in their proximal course, can benefit very easily from unroofing procedure. They don't have to reimplant this vessel, just unroof it, and they will do fine. So the most important thing in these patients with interarterial course is the origin, which is often oblique and it is slit-like. And if you look on the coronal image, they are elongated, slit-like, thin. And if you do a retrospective gated, this vessel get very much compressed, leading to symptoms in these cases. So that's why this course is also known as interarterial, is a malignant course which needs to be treated. In this case, this was a left main, which was arising from the right side cusp and going in between the vessels. Now, there is a differentiation between the interarterial and intraseptal, which can be sometimes tricky. This is an example of such case, 14-year-old male who had an irregular heart rate, led to cardiology consult, then abnormal echo. This is the echo which was done, and you can see, I cannot move this. Okay, you can see this left main coronary artery arising from the right side cusp, but we do not know whether it is going in between the vessels or it is intraseptal. So for that reason, we did a limited CT. Since he was a young kid, we just only did a part of the heart, not the entire heart, only the proximal course, because that's the only reason we want to do it. This is done many years ago when we had only a 64 detector scan. We decreased the KV, MA, and used the dose modulation. So his effective dose was only 3.4 millisievert at that time, which was pretty low at that time. And you can clearly see this vessel, anomalous vessel, which is coming from the right sided, it is coursing within the septum. And here is the septal branch. If you see the septal branch within the septum, this is the proof that this vessel is within the septum. And if you look carefully, these kind of intraseptal course are often kind of a stretched view, not typical curvilinear. It's more linear straight line appearance. So very easily gave an answer. Most of the intraseptal course are not considered malignant. However, we do not have a long-term data. Some people still operate on these cases, but they can be difficult, or at least watch carefully. And maybe these patients should not play exertive sports, etc. Now, rarely you might find anomalous coronary artery arising from the pulmonary artery, which is known as R kappa or L kappa. If it is right side, anomalous right coronary artery from pulmonary artery, L kappa if it is left-sided. This patient is a young patient. On examination, he had a murmur, and that leads to cardiology consult and abnormal echo. What we see on this retrospective Gady CT is that his coronary arteries are huge. This is the left main coronary artery, and here is the right coronary artery. They're all very much dilated. And anytime you see this kind of dilated coronary artery, the first thing come to mind is that there is a lot of collateral circulation. Something is going on. And when we carefully look at it, this patient actually had a origin of the right coronary artery from the pulmonary artery. So dilated coronary artery, either it is connected to a low pressure system such as pulmonary artery, or it is connected to some chamber which is low pressure. That's why there is more blood which is going into the low pressure system. So this is an incidental finding which was detected based on just murmur. And of course, these patients with R kappa often present later in life because this is not a life-threatening situation in the childhood, whereas L kappa often present early in childhood because they present with significant coronary steal leading to myocardial ischemia. Okay, now moving on to CT-FFR. As we all know, the anatomic stenosis, which is shown by CT or catheterization, does not mean that stenosis is hemodynamically significant. So we know majority of the cardiac events which happen from a non-significant stenosis, less than 50%. So when we look at catheterization, if you want to check the significance, the hemodynamic significance, we have to do invasive FFR, fractional flow reserve, which is more invasive, and it requires wire passing through the area of stenosis and looking at the pressure beyond and proximally and correlate with the aortic pressure. If it is less than 0.8, it suggests there is significant stenosis which needs some kind of intervention. Now it is possible, because of the computational flow dynamic, you can do the same, get same information from a non-invasive coronary CTA. There is no modification of coronary CTA protocol. No additional imaging is required. There is no extra radiation involved, and patient does not need adenosine as compared to the invasive FFR. So what you do it, currently you send this data to remotely to a lab, which is heart flow lab, and they will compute the data using a supercomputer and send you this kind of nice colorful images. The turnaround time used to be 24 hours. Now I think it is less than 4 hours, but it still involves money, which is not always paid by third parties. So that is one reason why we are not using it very often, but it's a very good modality. I think should be available at a cheaper rate and probably should be done on the spot within the department itself with a good turnaround time. These images which I am showing you are from Dr. Robert Campbell, who is the HMO of the, or CMO of the heart flow company. So how these can help you in the daily practice. So now we do a CTA which shows you significant disease that leads to catheter evaluation, and then you do the FFR. If it is low, you treat it. If it is not low, 0.84, you just do medical treatment. What if we, after CTA, we do CT FFR? For example, here, this patient has, same patient has disease, and if you do CT FFR, there is a low 0.74 value more distally. That means this patient need intervention. So now you do intervention, which is good. Whereas if you do CT FFR in the other patient, the number is 0.85. This patient does not need intervention. So this can be treated with medical management. So I think in this way, CT FFR can be a kind of a gatekeeper to allow appropriate patients to go for intervention and the others not to go invasive FFR or PCI. This is also helpful in those patients where there are multiple stenosis, one here, one there. So you can calculate multiple areas of the values FFR, and depending on that, it might help you decide which lesion is the culprit to attack or to PCI. So that's it.